Okay, let's jump right in. We're tackling venous disorders of the lower limb today. It's something that affects a huge number of people, often more than we realize.
It really is quite common. The figure your source mentions, up to 40% of adults in, well, resource-rich countries, that's staggering.
Right, and it's often just dismissed, isn't it? Seen as maybe cosmetic or, just part of getting older.
Exactly, but there's so much more going on physiologically.
And that's what you, our listener, really want to get into. You've brought us this very comprehensive medical text, Bailey and Love, and the mission is clear: understand this topic inside out.
Like the elite professionals in the field, as you put it.
Precisely. So we're going deep. Anatomy, physiology, what goes wrong, how it looks, diagnosis, management, the whole picture. Varicose veins, ulcers, VTE, even some of the less common stuff.
Our goal is to navigate this dense information, pull out the key insights, connect those dots for you.
Make it accessible, but without losing that crucial detail you need for real mastery.
So let's lay the foundation. Part 1. Anatomy, physiology, and this central problem of pressure.
Okay, basics first. Veins return blood to the heart. In the legs, that's uphill work.
Constantly fighting gravity. And the venous system holds a huge amount of blood, doesn't it? About 60% of your total volume, according to the text.
So it's a major reservoir.
Absolutely. And moving that blood requires a pressure difference. It's low up in the chest, near the heart, maybe 5–10 millimeters of mercury.
But down in the foot, standing still.
That pressure can shoot up to around 100 millimilli Hg. Think of that column of blood weighing down.
Wow, 100 millimilli Hg. That's significant. How does the body manage that gradient?
Well, a few things contribute. Breathing helps slightly. Inhaling drops the chest pressure.
Okay.
And the veins themselves have some tone. But the real workhorse, it's the muscle pump, especially the calf muscle pump.
The engine driving blood back up.
That's the one. External compression from the muscles.
Got it. But before we detail how that pump works, let's get the plumbing straight. The anatomy. Your source splits it into superficial and deep systems.
Correct. The deep system runs underneath the deep fascia, that tough layer around the muscles. Think of them as the main drainage pipes running alongside the arteries.
Protected, essentially.
Right. And the superficial system is closer to the surface, above that deep fascia. It eventually drains into the deep system.
So let's trace the deep system first. Where does it start?
Right down in the foot. Small veins, called venae comitantes, paired with the arteries. They collect blood and merge as they go up the calf.
The tibial veins, peroneal.
Exactly. Anterior and posterior tibial, and the peroneal veins. These join up, typically behind the knee in the popliteal fossa, to form the single popliteal vein.
And it gets blood from the muscles too, right?
Oh, definitely.
Huh?
Significant input from the calf muscles, the soleal and gastric nemeus veins. Your text specifically mentions the soleal sinusoids.
Sinusoids.
Yeah, they're like these large, irregular venous lakes or sacs within the soleus muscle. Big reservoirs.
Like sponges in the muscle.
That's a good analogy. They get squeezed during contraction. So the popliteal vein collects all this blood, then passes up through the thigh, through the adductor hiatus, becoming the femoral vein.
Okay.
Higher up, it's joined by the deep femoral vein, the profunda femoris vein, and becomes the common femoral vein in the groin.
And from there into the pelvis.
Passes under the inguinal ligament, becomes the external iliac vein, joins the internal iliac to form the common iliac vein, and then the two common iliacs merge into the inferior vena cava, the IVC, heading straight to the right atrium.
So foot, calf, popliteal, femoral, common femoral, iliacs, IVC, heart. That's the deep pathway.
That's the main route. Now, the superficial system, it's more variable, but there are two main stars,
Right.
the great saphenous vein, the GSV, and the small saphenous vein, the SSV.
And the source makes a point about their location in a specific compartment.
Yes, the saphenous envelope or compartment. They run between the superficial saphenous fascia and the deeper muscular fascia, fascia lata. This is really important anatomically, especially for ablation procedures.
Okay, GSV, the longest vein in the body.
That's the one. Starts on the inner side of the foot from the dorsal venous arch, passes just in front of the inner ankle bone, the medial malleolus, and runs all the way up the inside of the leg and thigh.
Stays medial.
Mostly. It curves a bit posterior around the inner knee condyle, then heads up the medial thigh.
And connects to the deep system where?
In the groin, at the saphenofemoral junction, the SFJ, it dives deep to join the common femoral vein, usually about 2.5 centimeters below and lateral to the pubic tubercle, but it can vary.
And it collects blood from tributaries near the groin. Why are these important?
Because they're common sites of reflux and recurrence if missed during treatment. The text lists the usual suspects. Laterally, the superficial inferior epigastric and superficial circumflex iliac.
Okay.
Medially, the superficial and deep external pudendal veins. And then coming up from the leg, often the anterior accessory GSV, the AEGSV, and the posteromedial thigh vein.
AEGSV sounds like a potential troublemaker.
It can be. It's a frequent variation, runs more anteriorly on the thigh, and can be mistaken for the main GSV trunk if you're not careful during scanning. Identifying it is key for planning.
Got it. That's the GSV system. What about the SSV, the small saphenous?
Starts on the outer side of the foot's dorsal arch, runs behind the lateral malleolus, the outer ankle bone, often alongside the sural nerve.
And ascends up the back of the calf.
Right up the midline, often in that groove between the heads of the gastrocnemius muscle.
Termination point. Famously variable, right?
Extremely. Most commonly, it joins the popliteal vein behind the knee, the saphenopopliteal junction, or SPJ, but it can join much lower or continue up the thigh as a cranial extension or connect across to the GSV system via the Giacometti vein.
So pre-op mapping is crucial for the SSV.
Absolutely essential if you're planning any intervention there.
Okay, deep pipes, superficial network. How do they connect?
Through perforating veins. They perforate the deep fascia. Critically, they have valves.
Valves ensuring one-way flow.
Exactly. Superficial to deep only, in a healthy state. They're found all along the leg, but key groups are in the calf, around the knee, mid-thigh. They let the muscle pump draw blood from the superficial system.
Right, back to the pump. How does all this anatomy work together when we move?
Okay, think about walking.
Okay.
Calf muscles contract. They squeeze those deep veins and the soleal sinusoids trapped under the fascia.
And the pressure generated is huge.
Really significant.
Yeah.
Transiently, up to 200, maybe even 300 millimilli-Hg inside that deep compartment.
But the blood goes the right way.
Because of the valves. Those one-way valves in the deep veins open under pressure, forcing blood up towards the heart. They snap shut to prevent backflow when the muscle relaxes.
And this upward flow pulls blood from the superficial system.
Yes, the rapid flow in the deep veins creates a sort of suction effect, drawing blood from the superficial veins into the deep veins through the competent perforators and the main junctions like the SFJ and SPJ.
And when the muscles relax,
Pressure drops in the deep system. Blood refills the deep veins, again drawn from the superficial system and also from distal deep veins. The valves in the perforators and superficial veins stop blood from flowing back out into the superficial system.
so it's a cycle. Squeeze, push up, relax, refill from below and outside.
Precisely. And the net effect during walking is a dramatic drop in the pressure within the superficial veins at the ankle.
From that 100 millimilli Hg standing still down to...
Ideally down to around 30 millimilli Hg. Figure 62.2 in your source illustrates this concept. This pressure reduction relies on everything working. Patent veins, good muscle function, and crucially competent valves everywhere.
Okay, that's the healthy picture. Now let's get into the problems. What causes venous disorders? What goes wrong?
The fundamental issue is venous hypertension. Sustained high pressure in the leg veins.
And that happens when the return mechanisms fail.
Exactly. Your source lists the causes systematically in Table 62.1. Broadly, things that increase pressure upstream.
Like in the chest or abdomen.
Right. Chronic lung disease, pregnancy, obesity, big abdominal tumors, even chronic constipation. They all make it harder for blood to drain out of the legs.
Makes sense. And problems with the pump itself.
Yeah, if the calf pump isn't effective. Immobility is a big one. Fused ankle joints, nerve damage, paralysis, anything stopping those muscles working properly.
And then structural issues within the veins.
Very common. Valves might be missing congenitally, or more often, they become incompetent, leaky. The vein walls can dilate, become tortuous, lose their elasticity.
Leading to reflux, backward flow.
Exactly. That reflux increases pressure downstream. Arteriovenous fistulas also cause massive hypertension by dumping arterial pressure directly into the veins.
Then blockages, actual obstructions.
Yes, a vein segment might be absent or blocked by thrombosis, a clot, or damaged by trauma or surgery. And external compression is another cause.
Like May-Thurner syndrome.
That's the classic example. The left common iliac vein gets squeezed between the overlying right common iliac artery and the spine. Virchow noted this long ago, but May and Thurner described this specific anatomy leading to stasis and potential DVT in the left leg.
So all these roads lead to venous hypertension. And the source talks about a vicious cycle.
It's a critical point. The high pressure itself causes more damage. It injures the vein wall, leading to inflammation, thickening, loss of elasticity, further dilation.
Which makes the valves even more incompetent.
Precisely. So the reflex gets worse, the pressure gets higher, causing more damage. It spirals downwards. For many patients, this might start with a primary weakness in the superficial vein wall itself, leading to dilation, then valve failure, then hypertension, and then the cycle kicks in.
And the end result of this chronic high pressure.
It eventually damages the surrounding soft tissues irreversibly. High pressure of the capillaries impairs nutrient exchange, causes inflammation, leading to the skin changes and ulcers we'll discuss. This tissue damage is the real consequence. So what? The visible veins are just one part of it.
That's a crucial distinction. The visible problem signals deeper trouble. Okay, part 2. Let's look at the clinical spectrum. What does this venous hypertension look like, and how do we classify it?
Right, the manifestations range quite widely. Your source walks us through them, from milder signs to severe complications.
Starting with varicose veins themselves.
The most obvious sign for many. Defined as dilated subcutaneous veins, 3 millimeters or wider. Often tortuous, but not always. Functionally, they're associated with valvular incompetence and reflux. Figure 62.3 shows typical patterns linked to the GSV, SSV, or that AGSV we mentioned.
And the smaller ones, thread veins, spider veins.
Those are telangiectasias, tiny little intradermal venules, less than 1 millimeter, reddish or purplish. Figure 62.4 shows these alongside reticular veins.
Reticular veins being slightly larger.
Yes, 1 to just under 3 millimeter. Bluish, often tortuous, subdermal veins, sometimes tricky to distinguish if the skin is thin.
Do these smaller telangiecasias and reticular veins cause physical symptoms on their own?
Generally, no. If they're present without significant underlying reflux in the larger veins, they're mainly a cosmetic issue. Still impactful for the patient's quality of life, but not usually causing physical pain or ache.
What about specific swellings, the saphenous varix?
Ah, yes. That's a soft bulge in the groin, usually painless, that appears when standing. It's essentially a blowout or dilation of the GSV right near the SFJ junction. Figure 62.5 shows one.
And it can mimic a hernia.
It can, yeah, but it typically vanishes completely when lying flat, which helps differentiate it. You might feel a thrill on coughing, but it's different from a hernia cough impulse.
Another sign mentioned is corona phlebicatica.
Right, that's a specific fan-like pattern of telangiectasias and tiny veins around the ankle or on the foot. The key point your source makes is that this is considered an early sign of advanced chronic venous disease, even though it involves small vessels.
Moving beyond the veins, general leg swelling, edema.
Edema indicates the venous system is struggling. Fluid builds up in the tissues, usually starting distally around the ankle. Often pitting edema press it, and it leaves a dent. It signals worsening venous function.
Then the skin itself starts to change?
With chronic high pressure, yes. You can get venous eczema, itchy, red, inflamed skin, sometimes blistering or weeping. Figures 62.6, 7, and 8 show examples.
And pigmentation, that brownish staining.
Hemosiderosis, it's a permanent discoloration, usually around the ankle or near incompetent veins. Figures 62.7 and 9 show this. It's from iron pigment hemosiderin leaking from capillaries under high pressure.
And these changes can become more severe, more structural.
Definitely. Like dermatosclerosis or LDS. This is chronic inflammation and fibrosis scarring of the skin and the fat layer beneath it. The lower leg becomes hard, tight, woody feeling, often tapered like an inverted champagne bottle. Figures 62.6 and 9 again. That's a hallmark of severe chronic venous disease.
LDS and atrophy blanche.
These are localized patches of white, scarred, atrophic skin, often surrounded by those tiny telangiectasias or pigmentation, also a sign of severe disease. Figure 62.6 shows this too.
And the final stage, the end point.
The venous ulcer, a full-thickness break in the skin that won't heal, typically in that gaiter area around the ankle. Figure 62.10 is a clear example. It's the culmination of chronic venous hypertension and the resulting tissue damage.
Quite a progression. To standardize describing all this, we have the CEAP classification.
CEAP is essential for clear communication. C for clinical, E for etiology, A for anatomy, P for pathophysiology.
Well, let's break that down. C, clinical signs.
It's a scale, C0 to C6, based on what you see and feel.
Okay.
C0, no signs at all. C1, telangiectasias or reticular veins. C2, varicose veins proper. C3, edema. C4A, skin changes like pigmentation or eczema. C4B, more severe changes, LDS or atrophy blanche. C4C, corona phlebicatica. C5, a healed ulcer. C6, an active open ulcer.
And you can add modifiers?
Yeah, is for symptomatic, A for asymptomatic, R for recurrent. So C4A means symptomatic pigmentation at the moment.
Okay. E, etiology, the cause.
E for congenital, E for primary, no known cause, likely inherent vein weakness. A for secondary, like after a DVT post-thrombotic syndrome. Or N if no cause is found.
A, anatomy, where's the problem?
As for superficial veins, 8 for perforator veins, add for deep veins, or N if no location identified. You can combine these, like AS, dermate evasive, all are involved.
And P pathophysiology, what's the functional issue?
PR for reflex, PO for obstruction, PRO for both, or PN if neither is identified.
So you can build a very precise picture. C6ES add pro tells you active ulcer, secondary cause, deep vein involvement with both reflux and obstruction.
Exactly. It's incredibly useful for standardizing diagnosis, planning treatment, and comparing research outcomes.
Right. Let's shift focus now in part 3 specifically to varicose veins, their diagnosis and management. They're the most common thing people associate with venous disease.
Extremely common, as we said, 30–50% of adults.
Risk factors.
Age is a big one. Prevalence climbs steeply. Gender tends higher in women. Family history is strong, suggesting genetics play a role. Body mass, height, pregnancy are also factors.
But lifestyle things like standing a lot, smoking, the evidence is less clear.
The source indicates the evidence linking those directly as primary causes is inconclusive, yes.
What about symptoms? What do people typically feel?
The classic symptoms are aching, heaviness, throbbing, sometimes burning or a bursting feeling in the legs.
Worse at the end of the day, better with elevation.
Typically, yes. Worse with prolonged standing or sitting, relieved by putting the legs up or wearing compression. Itching can occur, especially if there are skin changes. Ankle swelling is also common.
But confirming the veins are the definite cause can be tricky?
In uncomplicated cases, yes. The symptoms can be vague, overlap with musculoskeletal issues, etc. A trial of compression stockings is often helpful diagnostically. If symptoms improve significantly, it points strongly to a venous origin.
And quality of life impact.
Can be substantial. Even without complications, severe symptoms really affect daily life. And importantly, treatment aimed at the underlying reflux has been shown to provide significant, lasting improvement in quality of life scores.
Signs are usually the visible veins. You mentioned location can give clues. Medial leg for GSV, posterior for SSV.
Right, and that's the varix in the groin we talked about.
Okay, investigation. You said earlier, tourniquets and handheld Dopplers are out.
Completely abandoned in modern practice for planning intervention.
So the absolute standard is?
Duplex ultrasound scanning, mandatory before any intervention. Your source really emphasizes this. A detailed, bespoke treatment plan based on that specific patient's unique anatomy and reflux pattern mapped by duplex gives the best results. Ideally done by a skilled vascular scientist or a clinician.
Why is it so indispensable?
Because it shows you both the structure, the B-mode image, and the function, the blood flow via Doppler. You can see the veins, map their course, check for clots, measure size, and critically see if blood is flowing the wrong way, reflux, and pinpoint where it's starting and where it's going.
So what are the specific aims of the duplex scan in this context?
Several key things. Detect reflux, deep or superficial. Map the extent of superficial reflux, precisely which trunk, which tributaries, which perforators. Check for deep vein obstruction. Assess vein suitability for different treatments, diameter, tortuosity. Screen for superficial vein thrombus, and look for any signs of pelvic vein reflux or obstruction contributing to the leg problems.
That's a thorough checklist. How's the scan actually performed?
Usually starts with the patient standing, weight bearing on the opposite leg, maybe tilted head up to fill the veins. Scan starts in the groin, transverse view. Look for that Mickey Mouse sign. The common femoral artery is the head, the common femoral vein, and GSV is the ears. Check the SFJ competence right there. Trace reflux down the GSV or accessory veins.
And follow the GSV down the leg.
Trace its whole length. Look for it sitting in its fascial compartment. That saphenous eye sign confirms you're on the right track, especially for planning ablation. Measure diameter at key points.
Checking the deep veins at the same time.
Assess the common femoral, superficial femoral, deep femoral veins. Look for normal flow variation with breathing. If that's lost, it might suggest a blockage higher up, like in the iliacs. Check major perforators too.
And for the SSV.
Patient usually turns around, maybe prone with knee bent.
Yeah.
Scan from the ankle up the midline calf following the SSV. Check its competence, diameter, and crucially map its termination point, the SPJ, precisely in relation to the popliteal vein and knee crease. Assess the popliteal vein itself too.
How is reflex defined quantitatively on the stem?
By duration of backward flow after a provocative mover, like releasing a calf squeeze. For superficial veins and calf deep veins, it's significant if it lasts half a second, 0.5s or more. For the main deep veins higher up, it's 1 second, 1.0s or more.
Other imaging, rarely needed.
Very rarely for straightforward varicose veins. Maybe transabdominal vaginal ultrasound for pelvic sources, MR or CT venography, contrast sonography, IVUS, those are for complex cases. Often suspected obstruction. Varicography is pretty much historical now.
Okay, diagnosis confirmed with duplex. How do we manage varicose veins?
Practices vary. Experienced hands often use a combination of techniques. The source makes the point that treating symptomatic or complicated veins clearly improves quality of life. The evidence for treating purely asymptomatic veins to prevent future problems is less clear-cut.
Starting with the conservative option, compression stockings.
They provide external support, graduated pressure, highest at the ankle, improves deep vein flow, reduces superficial pressure, helps symptoms, definitely. Below knee are usually better tolerated than thigh length, classified by pressure class 1, 2, 3.
But they don't fix the underlying reflux, right?
Correct. They manage symptoms, but don't cure the vein problem. Compliance can be an issue. They can be hot, uncomfortable, hard to put on. And incorrect use, especially with arterial disease, can be harmful.
Yeah.
So the text positions them as helpful adjuncts, or an option if intervention isn't wanted, but notes that intervention generally provides superior QOL and is cost-effective long-term compared to just stockings.
Which brings us to the minimally invasive treatments, particularly endothermal ablation, a game changer.
Absolutely revolutionized treatment. Largely replaced open surgery for most standard superficial reflux. It's safer overall, highly effective, quicker recovery, better immediate QOL, often done under local anesthetic as an outpatient. Very cost-effective.
How does it work? Heat to close the vein.
That's the principle. A device, either laser fiber or radiofrequency catheter, is inserted into the incompetent vein, usually the GSV or SSV. Heat energy is applied to the vein wall, causing irreversible damage, thrombosis, and eventual fibrosis, sealing the vein shut.
And that tumescent anesthesia is vital.
Crucial. It's a dilute local anesthetic mixed with saline and bicarbonate, injected all around the vein under ultrasound guidance. It does three things. Numbs the area, squeezes the vein onto the device for better contact, and creates a protective fluid barrier and heat sink, shielding surrounding tissues, especially nerves, from the heat.
The two main types are EVLA laser and RFA radiofrequency.
Yes, EVLA uses a laser fiber. Different wavelengths and fiber tips exist, but the common 1470 millimeter wavelength targets water in the vein wall, generating heat.
Walk us through a typical EVLA procedure.
Okay, mark the vein standing. Patient lies down, often tilted head up. Cannulate the vein low down under ultrasound. Thread the laser fiber up. Tip positioning is key, just distal to the junction, usually 1 to 2 centimeters, is common practice to protect the deep vein, though some advocate for closer placement. Inject the tumescent anesthesia all around the vein. You see a halo on ultrasound. Then activate the laser and withdraw the fiber slowly, delivering a set energy dose per centimeter. Apply compression afterwards.
And RFA uses radiofrequency energy.
Right. The closure fast device is the main one described. It has a heating element on the tip that reaches a precise 120 degrees C for a fixed time, like 20 seconds. Treat a segment, withdraw the catheter a set distance, for example, 7 centimeters, repeat the cycle. Simple, controlled application.
How do EVLA and RFA stack up against each other?
Overall, the evidence suggests they're pretty much equivalent in terms of effectiveness and long-term outcomes. Both have very high success rates, over 95% closure.
Any subtle differences or advantages?
RFA might have a slightly gentler learning curve because of the automated cycles. It frees up the operator a bit during the cycle, doesn't require specific laser safety protocols. Maybe marginally less post-op bruising or pain reported in some studies, but recovery time is similar. EVL may be better for really large veins due to higher energy delivery. Consumables tend to be a bit cheaper. A standard laser fiber can sometimes be used off-label for perforators. RFA needs a special device for that, though the need to treat perforators routinely is debated. Both are excellent choices for most patients. The key message from Summary Box 62.1 is clear. Endovenous ablation is the modern standard, highly effective with minimal morbidity.
So after the main trunk vein is closed, what about the lumpy varicose veins that might remain?
Good question. They often shrink, but don't always disappear completely. Adjunctive treatment is common, sometimes done at the same time, sometimes later. Phlebectomy is a primary method.
Removing them through tiny cuts.
Exactly. Figure 62.1 times shows this. Small 1-2 millimeter stab incisions. Use fine hooks or forceps to gently pull out the varicose segments. Very effective for the visible lumps after the main source of reflux is dealt with.
What about techniques that avoid heat and tumescent, non-thermal, non-tumescent options?
Primarily sclerotherapy-based methods. Sclerotherapy injects a chemical irritant to damage the vein lining and cause closure. Liquid sclerosant alone has limitations.
So ultrasound-guided foam sclerotherapy, UGFS, was developed.
Yes, to improve efficacy. Mixing the sclerosant, like STS, with air or gas creates foam. This foam displaces blood better and has more surface area contact with the vein wall. Uses the Tessari method often, mixing liquid to gas 1.3 or 1.4.
How's UGFS performed?
Marks veins standing. Patient lies down, maybe leg elevated. Cannulate the vein under ultrasound, sometimes multiple spots needed. Inject small amounts of freshly made foam. Watch it spread on ultrasound, massage it along. Stop when it reaches the target, respecting volume limits per session, typically 10-12 milliliter max, due to small risks of systemic side effects. Apply compression.
How does it compare to thermal ablation long-term?
Generally lower long-term success rates, higher chance of needing retreatment compared to EVA or RFA.
Yeah.
Complications like phlebitis, inflammation, or skin staining can also be more common, especially outside specialist centers.
So why use it?
Advantages: avoids tumescent, so maybe less procedural pain. Can treat very twisty veins, inaccessible to fibrous catheters. Useful for residual veins or veins near ulcers where cannulation for thermal might be hard. Very low consumable cost. So it definitely has its place, often as an add-on or for specific situations.
Mechanochemical ablation, MOCA, like Clarivain.
MOCA combines mechanical disruption with chemical ablation. A catheter with a rotating wire tip spins inside the vein, physically damaging the lining, while liquid sclerosant is simultaneously infused.
Tumescent needed.
Can be done without it, which is an advantage for procedural discomfort. However, effectiveness compared to thermal ablation might be slightly lower in the medium to long term, according to some studies. Potential issues with the wire snagging, and limitations in very long veins due to catheter-length sclerosant dose. Your source suggests it's a decent option for needle-phobic patients needing axial treatment only.
And the newest option, endovenous glue.
Cyanoacrylate adhesive, like Venocil. A catheter delivers tiny drops of medical superglue inside the vein, which is then compressed externally to stick the walls together. Figure 62.23 shows the concept. Early results are good. Minimal procedural pain as no tumescent needed. Long-term data is still emerging. Currently the most expensive option in terms of consumables.
With all these minimally invasive techniques, is there still a role for traditional open surgery ligation and stripping?
A much smaller role than before. Minimally invasive methods generally offer comparable long-term results, but with significantly less pain, faster recovery, fewer complications like nerve injury or infection. But it's still a valid technique, used by experienced surgeons for specific cases, maybe very large veins, certain recurrent veins, patient preference, or where endovenous isn't feasible. Requires general or spinal anesthesia usually.
The classic operation.
Yeah.
SFJ ligation, GSV stripping.
Groin incision. Dissect down to the saphenothermal junction, identify all those tributaries we listed earlier, ligate them. Then ligate the GSV flush with the common femoral vein. Careful identification is critical here to avoid injuring the CFV. Then a stripper tool is passed down the GSV, usually just to the knee now, and the vein is pulled out. Figure 62.24 illustrates this.
Debates persist even with this technique.
Oh yes. Does closing the fascia help? Probably not. Does stripping to the ankle cause too much nerve damage? Yes, hence stripping to knee is standard. Does flush ligation itself provoke recurrence through neovascularization, new vessel growth? Some argue yes, suggesting ligating distal to tributaries, but evidence is weak.
And for the SSV, SPJ ligation and stripping.
It needs that accurate duplex map because the SPG is so variable. Patient-prone, incision over the junction. Again, debate. Flush ligation at the popliteal vein versus simple ligation more proximally. Flush might reduce stump recurrence. Simple might reduce nerve vein injury risk. Stripping versus just resecting segments also debated regarding recurrence versus sural nerve injury, often combined with phlebectomy.
Phlebectomy and sometimes perforator ligation are adjuncts to both open and endovenous main trunk treatments.
Right. Phlebectomy for the branches. Perforator ligation, the role is clearest in ulcer disease, though still debated. Less clear benefit in uncomplicated varicose veins. Can be done open, endoscopically, or increasingly ablated endovenously.
Main complications specific to open surgery.
Overall complication rate up to 20%. Minor stuff like wound infection. The main serious ones are nerve injuries. Saphenous nerve issues after GSV stripping, up to 7% to knee, higher to ankle. Sural nerve numbness pain after SSV surgery, up to 20%. Rare but serious is common peroneal nerve injury with SSC surgery, 4%. VTE risk is around 0.5%, so prophylaxis is needed.
And recurrence remains an issue, regardless of technique.
Unfortunately, yes. Clinical recurrence affects 10-35% by 5-10 years after surgery. Duplex finds some reflux and maybe 70% long-term. Causes: neovascularization, those new channels forming, residual reflux left behind, inadequate initial treatment, or new disease developing elsewhere. More common after SSV surgery, higher BMI. Stripping is better than ligation alone. Endovenous ablation might have slightly lower recurrence than surgery, but long-term comparative data is still maturing. Treating recurrence can be tricky. Open redo surgery has high complication rates, 40%, making endovenous options often preferable if feasible.
So wrapping up varicose veins, summary box 62.1. Common, impact QOL, treatment helps QOL and is cost effective. Duplex is essential for planning. Endovenous ablation is the current mainstay.
That's a perfect summary, a real paradigm shift in treatment over the last couple of decades.
Okay, let's pivot now in part 4 to the really severe end, venous leg ulcers.
A huge clinical problem. They're the most common cause of chronic leg ulcers, about 85%. Prevalence is significant, especially in older adults. The cost burden is enormous, both financially for healthcare systems, dressings alone are a huge expense, and personally for patients and their carers in terms of pain, mobility, and quality of life.
And the first step is always confirming it is venous.
Absolutely critical. Rule out other causes. Arterial disease is crucial. 15–30% of venous ulcers have an arterial component. Mixed ulcers also need to consider vasculitis, neuropathy, especially diabetes, trauma, malignancy, infection. Applying compression to a purely arterial ulcer can be catastrophic.
The pathophysiology, how the high pressure actually causes the skin to break down, seems like it's still not perfectly understood.
It's complex, and the exact molecular chain of events is debated. Old ideas like stasis causing lack of oxygen are out. Fibrin cuffs around capillaries, white cell trapping. These theories haven't fully panned out as the primary cause.
Current thinking involves inflammation and impaired healing.
Yes, things like reactive oxygen species causing damage, increased protein-degrading enzymes, dysfunctional fibroblasts, the repair cells, inhibited growth factors. It's likely a mix of these things, triggered by the chronic inflammation driven by the underlying hypertension. Whether they are cause or effect is still partly debated.
But the ultimate driver is agreed upon.
Ambulatory venous hypertension. High pressure when standing and walking that isn't relieved by the calf pump. The fact these ulcers almost exclusively occur on the lower legs strongly supports this. The hypertension can come from superficial reflux, perforator incompetence, deep vein issues, reflux or obstruction, or a combination.
What's the typical appearance and location?
Usually shallow with sloping edges. Base often has granulation tissue, maybe some sluve or exudate. Characteristically in the gaiter area, ankle to midcalf. Especially common on the medial side, near those cocket perforators. Ulcers outside this area, on the foot or high up the calf, should make you suspicious of other causes.
And a warning about the ulcer edge.
Yes, very important. If the edge looks raised, rolled, or thickened, you must biopsy it to exclude a Marjolins ulcer, a skin cancer arising in a chronic wound.
They often start after minor injury, and the surrounding skin shows signs of chronic venous disease.
Often, yes. The skin is already compromised. Itching might precede the ulcer. You almost always see surrounding pigmentation, hemosiderosis, and often lipodermatosclerosis (LDS) in chronic cases. The hemosiderin itself might contribute to the inflammation.
Examination needs to be thorough.
Definitely. Check the whole leg for varicose veins, signs of reflux. Palpate pulses carefully. Measure the ABPI, ankle brachial pressure index. Unless pulses are clearly booming, mandatory to assess arterial supply. Check sensation for neuropathy. Look for joint disease.
Investigations. Duplex again?
Duplex scan is key. Assesses the superficial, deep, and perforator systems for reflux or obstruction. Supports the venous diagnosis and guides treatment of any correctable reflux. If an ulcer is atypical or not healing, you need more investigations, biopsy for malignancy, blood tests for vasculitis, infection, anemia, etc.
Management hinges on attacking that hypertension.
That's the absolute cornerstone. Reduce the pressure. Two main strategies. Fix the plumbing, treat superficial venous reflux, and provide external support. Compression.
Treating superficial reflux is vital for healing.
Essential. If significant superficial reflux is contributing, ablating it, usually endovenously, is proven to speed up ulcer healing and significantly reduce the chance of it coming back. Early referral for vascular assessment and intervention is recommended. Summary box 62.2 highlights that early ablation can have healing time and is cost-effective.
And compression therapy.
The other pillar. High compression, properly applied, counteracts the venous pressure. Multi-layer bandaging systems like the 4-layer bandage are common and effective.
Describe the 4-layer system briefly.
Layer 1, padding absorption, wool. Layer 2, smoothing, creep. Layer 3, light elastic compression. Layer 4, cohesive bandage providing main compression and stiffness. The goal is 35–40 mmHg pressure at the ankle for pure venous ulcers. Needs skilled application for safety and efficacy.
What about compression if there's also arterial disease mixed ulcers?
This requires careful assessment with ABPI. If ABPI is 0.50–0.8, modified compression, maybe 20–30 mmHg, is often safe and beneficial. Some evidence for higher pressures with specific inelastic bandages too, but healing is slower. Below ABPI of 0.5 or ankle pressure 60 mmHg, compression is generally contraindicated until the arterial supply is improved via revascularization.
Other adjuncts treatments.
Pentoxifylline, an oral drug, can help microcirculation and augment healing when added to compression. Horse chestnut seed extract can reduce edema. Biological dressings or skin grafts might be used for very stubborn ulcers, but aren't routine due to cost and variable long-term success.
What doesn't generally work?
Routine antibiotics unless clear infection. Most specific ulcer healing pills lack good evidence, and the vast majority of topical creams and fancy dressings haven't shown superiority over simple non-adherent dressings under good compression.
Prevention of occurrence is key once healed.
Absolutely critical. Treat any underlying superficial reflux if not already done. And lifelong graduated compression stockings, usually class 2, below knee, are recommended for virtually all patients who've healed a venous ulcer, especially if there's residual reflux or deep vein issues. Must be worn daily.
Prognosis. Can they heal?
Yes, most can heal with optimal treatment. But recurrence is the big problem. 20–30% recur within 5 years, even with good care. Risk is highest after DVT, post-thrombotic leg.
So key points for ulcers, summary box 62.2. Huge burden, challenging, hypertension is the cause, ablation plus compression is the treatment, early ablation helps significantly.
That captures it perfectly. It's a chronic condition requiring aggressive initial treatment and lifelong preventative measures.
All right, let's broaden out in part 5 to some other venous conditions mentioned in the text. Pelvic congestion syndrome, PCS.
This comes up as a cause of chronic pelvic pain in women, often missed. Typically affects younger, multiparous women. Symptoms are that dull, aching pelvic pain, worse on standing, often non-cyclical. May have painful periods, heavy periods, bladder or bowel symptoms too.
Signs might include
Tenderness in the pelvis, but also look for vulval varicosities, hemorrhoids, or unusual varicose veins on the upper thighs, or buttocks fed from pelvic sources.
Diagnosis involves imaging the pelvic veins.
Yes, often starts with duplex ultrasound, transabdominal, transvaginal, looking for dilated, reflexing ovarian or internal iliac veins. MR venography or direct venography can also be used. Figure 62.29a shows a venogram.
Treatment.
Medical options exist, hormones, NSAIs, but the main interventional approach now is percutaneous embolization, blocking the reflexing pelvic veins with coils or sclerosant, often done by interventional radiologists. Figure 62.29d shows embolization coils, much less invasive than historical surgery.
Congenital venous anomalies born with vein problems.
Yes, variations like absent veins, aplasia, underdeveloped veins, hyperplasia, duplicated veins, or persistence of embryonic veins. IVC aplasia can mimic post-thrombotic legs. May-Thurner is considered congenital by some, but Chiari involves hepatic vein obstruction. Duplications are often incidental.
And Klippel-Trenaunay syndrome, KTS.
A specific triad: a vascular birthmark, port wine stain, abnormal veins, often large atypical varicosities due to persistent embryonic channels, and limb overgrowth, bone and soft tissue. Figure 62.36 shows this. Underlying issue is often absent or poor deep veins. Needs differentiating from Parkes-Weber syndrome, which has high-flow AV fistulas.
KTS management is mostly supportive.
Primarily conservative. Compression stockings are key. Laser for the birthmark. Sometimes surgery for leg length discrepancy. Removing the large varicosities is risky if they are the main drainage path. Higher VTE risk too.
Venous entrapment syndrome's veins getting squeezed.
Two main ones mentioned. Axillary vein entrapment at the thoracic outlet between rib and clavicle can cause Effort's thrombosis, Paget-Schroeder disease.
Presents as sudden arm swelling.
Often after exertion, yes. Might be linked to anatomical issues like a cervical rib. Treatment involves thrombolysis, confirming compression with imaging, figure 62.37b, then often surgical decompression like first rib resection.
And popliteal vein entrapment.
Vein squeezed behind the knee, usually by an abnormal gastrocnemius muscle. Can cause exercise-induced pain swelling before thrombosis. Treatment is surgical release of the muscle.
Okay, part 6. Veins involved in trauma and tumors.
Venous injury is common in trauma, often alongside arterial bone injuries. Meji-axial vein injuries need repair if possible, especially with arterial injury, to reduce limb loss and long-term problems like PTS. Popliteal fossa injuries are high risk.
Mechanisms, laceration, crush, etc.
Yes. Direct cuts, bruises, avulsions. Figure 62.38 shows types. Iatrogenic injury also happens. Complications include bleeding, thrombosis, embolization, AV fistula formation.
Clinical signs might be subtle initially.
Can be overshadowed by other injuries. But massive bleeding from large veins, pelvic IVC, is life-threatening. Look for expanding hematomas, limb swelling, engorged veins, cyanosis.
Management starts with ABCs, control bleeding.
Always stop major hemorrhage, pressure, maybe tourniquet temporarily, surgical control, fracture stabilization, resuscitate, manage coagulopathy. Most accessible bleeding stops with pressure, intervention, surgery, endovascular, needed if pressure fails or limb is threatened.
Formal repair for major injuries.
If feasible. Options depend on the defect, figure 62.39. Simple suture, lateral venorrhea, patch graft, or interposition graft using patient's own vein, jugular saphenous, is preferred over synthetic grafts like PTFE, especially in trauma due to infection risk. End-to-end anastomosis if no tension.
Adjuncts, anticoagulation.
Often used post-repair. Creating a distal AV fistula to boost flow is controversial. Tetanus antibiotics are standard for open wounds. Fasciotomy strongly considered for combined lower limb injuries.
Prognosis for repair.
Good. 70–80% patency for major vein repair. Improves outcomes versus ligation. But ligation may be life-saving if repair is impossible immediately.
Venous tumors rare.
Yes. Venous malformations, VMs, are relatively common congenital vascular anomalies. Can be superficial or deep. Present is swelling, pain, maybe a bluish compressible mass. Figure 62.4 AYA shows a clinical example. Can thrombose, causing pain. MR imaging is key. Figure 62.4 URB. Treatment is complex, often involves sclerotherapy by specialists. Surgery is less common initially.
Malignant vein tumors.
Leiomyomas, benign, and leiomyosarcomas, malignant, arising from the vein wall, smooth muscle, are extremely rare. Slow growing, present with mass, pain, or obstruction. Seen as filling defects on imaging. Figure 62.41 shows an IVC leiomyosarcoma. Treatment is resection, often needing vein reconstruction.
Cystic degeneration.
Uncommon cause of vein blockage by cysts in the wall. Treated surgically.
Right, final section, part 7, venous thromboembolism, VTE, hugely important.
A major cause of preventable death and disability, especially in hospitalized patients, includes SVT, superficial, and DVT.
DVT being the main source of serious complications.
Yes. Immediate risk of PE, pulmonary embolus, leading to death. Long-term risk of post-thrombotic syndrome, PTS.
Yeah.
Chronic leg swelling, pain, skin changes, potentially ulcers from vein damage. Figure 62.3 shows PTS features.
Etiology still comes back to Virchow's triad.
Still the cornerstone.
Yeah.
Endothelial injury, stasis, abnormal flow, and hypercoagulability, abnormal blood.
Main risk factors, hospitalization is key.
Biggest single risk factor, surgery, SP at ortho, cancer, major trauma, lower limb pelvis, immobility, pregnancy, OCPs, obesity, heart failure, cancer itself. These are listed in table 62.2.
Stasis from immobility, travel, endothelial damage from inflammation or previous clot.
Exactly, and hypercoagulability or thrombophilia, table 62.3. Inherited conditions like factor V Leiden, protein CS deficiency, antithrombin deficiency, acquired issues like antiphospholipid syndrome, should be considered an unprovoked or recurrent VTE or strong family history.
How does the clot form and embolize?
Starts usually in calf vein valve pockets. Platelets aggregate, fibrin mesh forms, traps red cells, grows, propagates proximally. Figure 62.31 shows propagated thrombus. If a piece breaks off, it travels up.
Through IVC, right heart.
And lodges in the pulmonary arteries. That's a PE. Size determines impact from none to chest pain, breathlessness, to cardiovascular collapse and death.
Diagnosis is tricky clinically.
Notoriously unreliable. Classic DVT signs, calf pain, swelling, tenderness, are nonspecific. Holman sign is useless. PE symptoms, chest pain, shortness of breath, hemoptysis, can mimic many things. Bilateral DVTs occur, need objective tests.
Investigation is mandatory.
Absolutely. Clinical prediction scores like Wells, table 62.4, 62.5, can help guide testing, but aren't perfect.
Gold standard for DVT.
Venous duplex ultrasound. Compression ultrasound, just checking compressibility of CFV popliteal, is quicker, but misses calf DVTs. Management of isolated calf DVT is debated.
And for PE.
CT pulmonary angiogram, CDPA, is the standard.
Yeah.
Figure 62.35 shows filling defects. Venography, figure 62.34, or pulmonary angiography are rarely needed now.
Differential diagnosis for DVT includes Baker's cyst and hematoma.
Yes, ruptured Baker's cyst is a classic mimic. Muscle tear, cellulitis, even arterial issues. Duplex helps sort it out. PE differentials include MI, pneumonia, pleurisy.
Prophylaxis prevention is vital in hospital.
Paramount. Mechanical methods, stockings, pneumatic compression, have some benefit, but recent evidence questions their added value if pharmacological prophylaxis is given. Avoid stockings in arterial disease.
Pharmacological is more effective, but higher bleeding risk.
Generally, yes. LMWH, low molecular weight heparin, daily subcutaneous injection is the standard if kidney's okay. Better than old unfractionated heparin. Alternatives like fondaparinux exist for specific cases. Risk stratification, Table 62.6, guides who gets it, medium-high risk.
Treatment of diagnosed DVT.
Immediate anticoagulation is key to prevent propagation and PE. Treatment dose, LMWH initially, then transition to oral anticoagulants for at least 3 months, maybe longer. NOACs, rivaroxaban, apixaban, dabigatran, are generally preferred over warfarin. Now, similar efficacy, less major bleeding.
IVC fill.
Only if anticoagulation is absolutely contraindicated due to bleeding risk. Temporary measure to catch clots.
Endovascular thrombus removal. Growing role.
Yes, for acute, extensive proximal DVT, iliofemoral. Catheter-directed thrombolysis or mechanical removal aims to clear a clot quickly, reduce valve damage, and prevent long-term PTS. Beneficial in selected patients.
PE treatment.
Most get anticoagulation. Severe PE with hemodynamic compromise may need thrombolysis or embolectomy.
Finally, SVT superficial thrombophlebitis.
Clot in a superficial vein, often inflamed. Causes trauma to varicose veins, IV lines, cannulas, systemic links like Berger's disease, malignancy, thrombophlebitis migrans, coagulation disorders can coexist with DVT.
Looks like a tender cord under the skin.
Red, hard, tender linear segment. Skin might discolor later.
Investigation must include checking for DVT.
Yes, duplex scan of deep veins is crucial as concomitant DVT occurs and changes management significantly. Bloods is needed. Consider underlying causes if recurrent or migratory.
SVT treatment.
Most localized SVT resolves with NSAIDs, perhaps topical heparinoid. Anticoagulation, often therapeutic dose LMWH for a short period, for example 4 to 6 weeks, maybe with fondaparinux, is indicated if it's extensive, near a deep junction within 5 centimeters, or associated with other risk factors. Surgery, ligation excision, very rarely needed.
So, wrapping up VTE, summary box 62.3. Common, potentially fatal PE or disabling PTS. Risk assessment prophylaxis vital. Anticoagulation is mainstay or treatment. Early clot removal, sometimes used for PTS prevention.
That covers the critical points well. A condition demanding vigilance from all healthcare professionals.
Right, what a deep dive that was. From the fundamental anatomy and the physics of venous pressure, all the way through varicose veins, the devastating impact of ulcers, the nuances of diagnosis with duplex, the revolution in minimally invasive treatments, and the critical importance of VTE. We've covered a massive amount of ground from your source material.
We really have.
Yeah.
Connecting the dots from how that calf pump works or fails to the downstream consequences like LDS or ulceration. Understanding why vapping reflux with duplex is so fundamental to planning effective treatment with EVLA or RFA or even foam.
And hopefully, by working through this level of detail, you, our listener, feel much closer to that goal of mastery. Seeing beyond just the surface signs to the underlying pathophysiology and the rationale behind modern management, grasping why that pressure gradient matters, why valves are key, why hypertension is the enemy.
It's about building that robust framework, understanding the why behind the what's.
Exactly. So here's a final thought to leave you with, building on what we've discussed. We've seen incredible progress with endovenous techniques effectively treating superficial venous reflux, the main driver for many patients with venous ulcers. Yet, ulcer recurrence remains a major challenge even after successful ablation. So the provocative question is, does this persistent recurrence, despite fixing the plumbing, tell us that simply reversing the hypertension isn't enough once severe tissue damage like LDS has set in? Does it point towards irreversible changes in the tissue microenvironment, perhaps needing future therapies that target the biological processes of chronic inflammation and impaired healing in addition to correcting the underlying venous hemodynamics?
A really important question. It highlights that managing the end-stage complications might require more than just addressing the initial cause. Definitely food for thought and an area for ongoing research.